Hello, ladies and gentlemen. Welcome to Triple in Media. I am Dr. Nik Nikam, a cardiologist. In this presentation, we're going to look at a comprehensive approach to doing an echocardiogram on a patient with suspected aortic stenosis. What are all the different things we look for, and also use all the calculations that are required to arrive at the accurate aortic stenosis assessment, including many other associated features of the heart, the left ventricular size, left ventricular function, left atrium, aorta, and many other structures. So this is a comprehensive approach, and this is based upon a book I have written, which is on echocardiography and Doppler reference book. Let me give you a brief inside look at this book. I'll take you right to my book here, if I can get here. Here's a book which is available on Amazon.com. This book is available on Amazon.com. It's less than $30. I'm going to just get you into the book itself and show you the chapters. We've got aortic stenosis grading, aortic stenosis severity, aortic stenosis in presence of low output, low gradient status. So all of these things are covered in the book, but I'm not going to cover what is in the book. You can just glance through them, if you happen to be on Amazon. And these are all the things that are covered as far as understanding the aortic stenosis and all the different calculations that are used for diagnosing aortic stenosis, especially low gradient, low output aortic stenosis, which is a very important factor that needs to be differentiated from pseudo-aortic stenosis. So let's get right into the presentation. And these are some of the things we are going to be looking at when we do an echocardiogram in a patient with suspected aortic stenosis. Everything needs to be looked into in the context of aortic stenosis, the patient's age, and the left ventricular size, mitral calcification, thickening of the mitral leaflets, left atrial size is extremely important, the aortic root size is important, the ascending aortic size is important, the character of the leaflets, namely they are thickened, calcified, fibrotic, nodular, and the movement of the valves, whether they are unicuspid, bicuspid, tricuspid, or quadricuspid valves. Again, talking about mobility, thickness, and fibrosis, nodules, many other features. We can also look into an M mode for measurement of timings. We look at the right ventricular size to see if the patient has associated heart failure, which may reflect in terms of pulmonary hypertension. And here's a cross section of the aortic root where we're going to look at particularly for bicuspid and unicuspid valves. Usually bicuspid is common in the adult population, but in pediatric population it's not uncommon to see a unicuspid aortic valve with a tiny pinhole type of narrowing. So keeping these things in mind, let's start with the premises. The normal systolic cusp separation should be more than 1.5 centimeter square. So if you see the opening here, during systole, it should be minimum of 1.5 centimeter square or centimeters. Then we're going to look at the left ventricular hypertrophy, which may suggest presence of hypertension or long-standing critical aortic stenosis. There may be proximal septal thickening, which is usually seen in patients in the age group 70 and beyond. We look for any evidence of reduced left ventricular ejection fraction, in which case we may be dealing with a patient with aortic stenosis with low cardiac output, low gradient, which has to be differentiated using a dobutamine stress test or something similar to that. Look at the left atrial enlargement, because left atrial enlargement may be an important factor. If the patient has significantly elevated left atrial size, that may be a signal that this patient is more likely to go into atrial fibrillation, and patients with atrial fibrillation tolerate aortic stenosis extremely poorly, and that's an indication to watch for when we are doing an echocardiogram. Right ventricular dilatation, as I told you, could be secondary to pulmonary hypertension from a concomitant heart failure associated with aortic stenosis. Impaired left ventricular function, reduced global longitudinal strain is something that is picked up by the global longitudinal strain, which may not be evident by just glancing at the left ventricular wall motion and function by naked eye. In addition to that, we also look for any post-stenotic dilatation of the aortic root, or look for any evidence of like membranes just beneath the aortic valve, which may suggest subvalvular aortic stenosis. So keeping these things in mind, we are just looking at the parasternal long axis. There are so many factors that we can deduct by just looking at the parasternal long axis, and if we go to the apical 5-chamber view, we can literally see the aortic root also, which is the location where we are going to be using the pulse wave and the continuous wave Doppler to look for left ventricular outflow tract VTI and aortic valve VTI, aortic stenosis VTI. Again, we can measure the left atrial size and note that there may be evidence of calcification. All of these things may account for the degree or severity of aortic stenosis. Again, calcification of the aortic leaflets is also an important factor, and it will be used as an important factor in determining the degree of aortic stenosis in patients with low cardiac output. And this can be done either by echocardiography or more specifically using a cardiac CT, which will detect the presence of calcium on the aortic leaflets. Keeping these things in mind, let's move on to, we need to look at assess concomitant valvular abnormalities, especially in patients with rheumatic heart disease. They may have rheumatic mitral stenosis or tricuspid stenosis, and there may be associated mitral regurgitation also. Elevated left ventricular evaluate filling pressures, which is an important thing, and patients with aortic stenosis may also have stiff ventricles which are hypertrophied, which can lead to diastolic dysfunction, and measuring all the parameters of the aortic diastolic dysfunction is exceedingly important in evaluating the overall significance of the aortic stenosis. Let us not forget the elevated left atrial pressure, which is characterized by left atrial enlargement, tricuspid regurg of 2.8 meters or greater, or E to E prime of greater than 15, and reversal of the pulmonary systolic diastolic waveforms. All these things play an important role in assessing the degree of aortic stenosis. Again, we need to use multiple imaging windows, including suprasternal notch, to look for the velocity of the aortic jet to get the maximum value that we can. Then consider other modalities like CT, MRI, because aortic stenosis is a very critical condition. Those patients who become symptomatic, they deteriorate within 2 to 3 years, and hence it is important to identify. Echocardiography will be the central focus in identifying patients with the critical aortic stenosis, the degree of aortic stenosis, left ventricular function, right ventricular function, and other associated features. So that will help us to determine if we are dealing with an aortic stenosis that can be handled with a TAVR, or whether the patient needs to go for aortic valve surgery, or they can be just followed up medically based upon all these different parameters put together. Here is a short axis which we just looked at. We particularly look for any evidence of bicuspid valve calcifications, nodules, and we can do the outline of the aortic valve opening, but it is exceedingly difficult to look for an aortic valve opening in the short axis, especially in the elderly population where there could be a significant challenge. As I said, you can look at the left atrial size, we can look for pulmonic regurgitation here, look for tricuspid regurgitation, and when you're looking at these things, you also want to look for any evidence of the presence of pacemaker, which may suggest suggest to you that there may be some other conditions associated with this patient which may also account for the patient's symptoms. And if the patient is having a pacemaker, if it's just a single chamber pacemaker, there could be septal abnormalities related to the ventricular pacing. Here is a like a 3D image showing calcification and also nodules, fibrosis, narrowing of the aortic. This is the degenerative type. This is the bicuspid aortic valve. This is the rheumatic one, which is morely associated with the fibrosis, calcification, and nodules. Here is the simple formula that is used to measure to determine the degree of aortic stenosis. When the blood flows through the left ventricular outflow tract into the aorta, depending upon the orifice of the aortic valve, the velocity of the blood changes. In other words, when the blood is being pumped from the left ventricle into the left ventricular outflow tract, it has a certain velocity, which is measured by the velocity time interval or integral, which is VTI. And this velocity is going to change right at the region of the stenosis. So beyond the stenosis, the velocity is going to be significantly higher to compensate for the reduction in the aortic valve area. And this is the formula that is used to calculate. If we know the cross-sectional area of the left ventricular outflow tract, which we can determine by using the diameter of the left ventricular outflow tract just beneath the insertion of the aortic leaflets, that gives us a left ventricular diameter, and using that we can calculate the left ventricular outflow tract cross-sectional area. And we can measure the velocity using the pulse Doppler in the left ventricular outflow tract region. And with that, we know what the velocity of the jet using continuous wave in the aortic plane. Then we can calculate the unknown factor, which is the aortic valve area. So this is a very simplistic explanation, but profoundly it is the foundation for doing aortic stenosis grading and determining the severity by using this what is called the continuity equation. That is, pressure and volume are interrelated. When the orifice through which the blood can go through is reduced, then the pressure increases. And that's what we measure in the aortic region. All right, so let's take, for example, one patient who has a body surface area of 2.1 meters square. And let's assume the left ventricular outflow diameter is approximately 2.2, and the left ventricular VTI, or velocity time interval, or integral as it is called, is 20 centimeters. Now we have this aortic valve continuous wave Doppler with a maximum velocity of 4.58 meters, which should be converted into 458 centimeters per second. Then we get an aortic VTI of 94.4. If you look at the left ventricular outflow tract VTI, which is 20, and the aortic VTI, which is 94.4, the dimensionless aortic stenosis grading uses this one by dividing the left ventricular VTI with the aortic VTI to determine, what percentage of the stenosis is there. Obviously here it is greater than the aortic valve area is less than 20% of. If it's less than 25%, then it is supposed to be critical severe aortic stenosis. In this case it is, because if you can see, if you divide this, you're going to get less than 25%. So the left ventricular outflow tract is calculated by using pi r square, that is 3.14 multiplied by 2.12, you divided by 2, which is 1.1, to the square of that would be the number we get here, 3.80 centimeters square. Once we know the left ventricular area, which is the cross-sectional area. We know what the VTI for the left ventricular outflow tract is, which is 20. So we add those together and divide that with the VT of the aortic valve region located here using the continuous wave Doppler by 94/4. So we get a valve area of 0.81 centimeter, and when it is indexed to the body surface area, the valve area is 0.39 centimeter square, which means this patient has critical aortic stenosis. So this is the formula we use. Besides just using a formula, we need to look at many other factors. I told you, we need to look at the patients with gradients less than 40 millimeters of mercury. Do they have severe aortic stenosis? How do we determine? They may have low gradient, they may have low cardiac output, and all these factors are going to be taken into consideration. Is considered less than 0.6 centimeters is considered severe aortic stenosis. Between 0.6 and 0.85 centimeter per meter square. Please pay attention to these numbers here, because we are not looking at just raw number. We are looking at the indexed centimeter per meter square. So when the aortic valve area index is 0.39, this indicates severe aortic stenosis. And here is a little chart which most of you have seen or been familiar with this one. If the peak velocity is 2.9, it is mild aortic stenosis. Velocity, we are talking about continuous wave aortic valve velocity, which is 3.3 to 4 is considered moderate. Anything greater than 4 is considered severe. I mean, this is just a guideline. This is just one of the parameters that we're going to be using in addition to many other features, namely the gradient. We got the velocity gradient. When the gradient is greater than 40, it signifies severe aortic stenosis, and aortic valve area less than 1, and an index of 0.6, and a velocity ratio, which is the dimensionless index of less than 0.25. So these are all calculations which are based on the continuous wave Doppler of the aortic region, and this is one of the aspects. But as I said, when you're doing a patient, when you're looking at an echocardiogram of a patient with aortic stenosis, you need to look at the whole composite picture, because you have to determine what is the next step. Does this patient need medical follow-up? Does this patient need stress test? Does this patient need cardiac catheterization? Does this patient need TAVR? Is he a candidate for surgery? All of these things need to be taken into consideration. And here's another example. We have a Vmax of 364, that's less than 40 4 meters per second, and a mean gradient of 34. It gives a valve area of 0.53 and an index of 0.48. Is this severe aortic stenosis? The answer is we don't know. There are so many other factors that need to be taken into consideration in this particular patient, because the gradient is not greater than 4 meters per second. Number two, the VTI is 0.53, which is not a real big number. Number three, we don't have the left ventricular function. We don't have the stroke volume. So we just can't say by this one. If the patient has a low cardiac output, low gradient aortic stenosis, then we may have to do certain tests to see if this is true aortic stenosis or if this is pseudo aortic stenosis. So let's look at a couple of more examples. We already saw this one. Here's another example with the aortic gradient of 6.7 meters per second, the velocity across the aortic valve using continuous wave. In addition, there is also some degree of aortic regurgitation, as is seen here in the pulse, in the wave Doppler. Here's another example of 4.87 meters per second and a VTI of 113. Is this severe aortic stenosis case? I mean, I'm just basing on two parameters: the gradient, the velocity, the mean gradient 57, and VTI. Based upon these three numbers, I would say we are dealing with a severe aortic stenosis. As I said, we can take many other features into consideration. Here are some examples of mild aortic stenosis where the velocity is 2.6, a mean gradient is 17. And here's moderate stenosis 3.2, a mean gradient of 25. And here's a severe aortic stenosis, velocity of 5.6 meters per second, a mean gradient of 75 millimeters of mercury. And here comes a subaortic stenosis with a velocity of 3.6 and a mean gradient of 32. So that's why I said when we're doing an echocardiogram, we need to look for not just aortic stenosis, calcification, and restricted movement of the aortic valve. We need to look at the structures beneath the aorta. Is there a septal thickening that can be causing some degree of obstruction in small ventricles, especially elderly patients with hypertension? Now comes the real challenge. What do we do with patients with aortic stenosis with a gradient which is like 35 and has a valve area which comes out to be 0.5 or 0.4? In those cases, we may be dealing with a pseudo-aortic stenosis, or it could be related to low output, low gradient aortic stenosis. The low output, low gradient true aortic stenosis would have a significant impact in the patient's outcome, which needs to be taken into consideration. Let's see if we can start out by using a dobutamine stress echo. So we're going to start off with a left ventricular ejection fraction of less than 40%, which is abnormal. The normal ejection fraction should be 55 to 70%. And again, we have an effective orifice area of less than 1 centimeter. When we do the dobutamine stress echo, if we can increase the stroke volume by 20%, that suggests the left ventricular reserve function has the ability to increase the stroke volume with increased myocardial stimulation. If we can increase the stroke volume, if the gradient goes up beyond 4 meters per second, if there is evidence of calcium noted on CT, then we are dealing with a true aortic stenosis, in which case a SAVR or a cabbage may be an indication. However, if the gradient is less than 4 meters per second and the effective orifice area is greater than 1.2 centimeter square, if the calcium score is less than 1650, here this is a number which is greater than 1650, if its calcium score is less than 1650, then we may be dealing with pseudo-severe aortic stenosis, which can be followed medically. On the other hand, if the stroke volume is increase in stroke volume is less than 20%, these patients do not have any left ventricular flow reserve. In these cases, does this patient have a high calcium score of greater than 1650? If that is the case, then if the effective orifice area is 0.10 to 1.2, which you calculate using the Doppler studies, then you are dealing with severe aortic stenosis. Then this patient, if it's a high risk surgical candidate, a TAVR may be something to be considered. Here's an example of a dobutamine stress test, REST. We have a LVOT of 22 millimeters, VTI of 14, which is normal, stroke volume of 53, and stroke index of 30 ml. And here's the aortic valve. The velocity is 3.3 meters, gradient 27. So it doesn't look severe in this case, even though the valve area comes out to be 0.8. It doesn't say here if it's indexed. But anyway, when we do the stress test in this patient, the VTI of the left ventricular outflow tract remains pretty much the same. The stroke volume went up by 8 ml. So that's an indication that there is some evidence of left ventricular myocardial reserve function left. Now the gradient has gone up, the velocity has gone up, the VTI has significantly gone from 67 to 95. Now the aortic valve area is 0.6 centimeters. This is a condition, this is a situation where a stress echocardiography can greatly help in determining whether you're dealing with a true aortic stenosis in a patient with reduced stroke volume or reduced ejection fraction compared to a patient who may have a pseudo aortic stenosis. Here's another important point I want to say: acceleration time. It's an important measure that we need to keep in mind, because in those patients whom we feel the aortic stenosis is not critical, but they can be followed, in those patients, by doing serial echocardiography, we can follow the acceleration time. As you know, as the aortic stenosis goes from mild to moderate to severe, the time it takes to reach the peak, the systolic pressure peak, increases, and that is the acceleration time, which is going to be increased. Normally the acceleration time is like less than 60 milliseconds, and here you start measuring the acceleration time from the beginning of the aortic valve opening to the time it reaches the peak. So this is your acceleration time in milliseconds. If we have an acceleration time, and a year later, if the patient comes back with some symptoms, and if the acceleration time has not changed a whole lot, then it may be that the aortic stenosis hasn't gotten worse. That's one of the indexes that we can use, but that's not the end of it. And here's how you measure the acceleration time from the beginning of the aortic valve opening to the time it reaches the peak velocity. So 58 milliseconds. And here's a worsening of the aortic stenosis where it can be like 126 millimeters of mercury. So that gives you an index of whether the aortic stenosis is progressing, even though some of the features on the echocardiography may not be clearly evident. So the time the peaking of the curve, this is what we used to call in the olden days the delayed carotid upstroke, which was like significant for aortic stenosis. Anyway, this is another example showing that. So ladies and gentlemen, this is summarizing the acceleration time. The normal is between 58 to 75, and we follow this acceleration time with subsequent echoes to see if the acceleration time has remained same or whether it has increased over the interval. And anytime the normal acceleration time over ejection time, the total ejection time ratio is, the normal is 0.24. And if the acceleration time over ejection time ratio is greater than 0.35, this may indicate severe aortic stenosis. So ladies and gentlemen, this is further explanation of the diagnostic value of acceleration time. You can just pause this and read it, because this is one more additional feature that is available. This is more for follow-up of patients who do not need immediate intervention as such after the diagnosis of a moderately significant aortic stenosis. So ladies and gentlemen, this is a quick synopsis of the aortic stenosis by echocardiography and Doppler. And this is based on my book, Echocardiography and Doppler Reference Book. It's available on Amazon. You can check it out. And I also have several other chapters. I just did a chapter on mitral regurgitation, comprehensive review of mitral regurgitation. You can watch that. And I will see you in the next presentation. Thank you so much for watching.